Yeah, so thanks for the help as well, and for giving me the great honor to close off this workshop. So I guess we finish off as we sort of started, kind of combining well-being and health econ research. This paper is a joint project with Anthony, Andrew, and Conchita, and it is about healthcare workers and their life satisfaction during COVID. So I promise I will be hopefully short, and so we can all enjoy the social dinner. So essentially, as we know, the pandemic had a detrimental effect on the mental health and well-being of the general population. But we can also think that different types of individuals and different types of workers might have had different experiences of the pandemic itself. If we think about essential workers, they might have had a completely different experience to non-essential workers, since they could still go out to do their jobs because it was considered essential to continue our societies. So this is how we started this, with a specific focus on healthcare workers. As we know, healthcare workers were essential, especially during the pandemic, but even nowadays, their well-being is fundamental to maintain a healthy and sustainable healthcare system. So understanding their well-being is important, not only for the retention of healthcare workers, which is a systematic problem of NHS all around the world, but also to deliver high-quality services, healthcare services. So with this paper, we try to answer to these two research questions. First of all, how have healthcare workers reacted in terms of their well-being, in terms of their life satisfaction during the pandemic in comparison to the rest of the workforce? And also if the difference that we observe in this life satisfaction gap between different workers can be explained by the pandemic policies and the pandemic evolution. So just to give you a preview of the results, if in case I lose you in the next 20 minutes. So we found that healthcare workers were on average happier or more satisfied with their lives compared to the rest of the workforce during the entire pandemic period. And we observed roughly 3 years. And why is it potentially that healthcare workers reacted differently? We look specifically at the stringency of the pandemic policies implemented, and we saw that healthcare workers were not negatively affected by it, at least in terms of their life satisfaction. And this potentially can be explained by their intrinsic value and fulfillment that they derive from their own profession. On the other side, however, when COVID was at its peaks in terms of the COVID-related death, healthcare workers had a large substantial deterioration in their well-being. And this is possibly linked to the deteriorated working conditions that healthcare workers had to work with. If we can think about it in that period, there were overcrowded hospitals, lack of medical equipment, and even medical personnel. And also there might have been a rising fear of COVID among the healthcare workers. So this paper adds to a couple of strands of the literature. First of all, on the well-being of healthcare workers. So far, the published papers have mainly focused on mental health, specifically mental health outcomes, so like burnout, stress, and depression, while in this paper we examine an overall measure of well-being. And also, they mainly focus on small cross-sectional samples of individuals, mainly focusing only on healthcare workers. So here we also look at healthcare workers and the rest of the workforce more broadly. We added to the literature on the effects on the pandemic on essential workers. In general, this literature is focused on the beginning of the pandemic, and also they did not really disentangle the effects of the pandemic evolution from the pandemic policies. This is something that we do over, as I mentioned, almost 3 years. And also, finally, we add to this pandemic impact on the well-being of the general population, showing heterogeneous effects among workforce categories. So luckily, Alessio presented this data already yesterday, so I'm not going to spend too much on it. Just to remind you about this data set, is come here. It's a representative sample based on age, gender, and region of residence of these 5 European countries, France, Germany, Italy, Spain, and Sweden. And we have many informations, life events, health, mental health, and also the standard characteristics. As in the paper with Alessio, we also use the Oxford COVID-19 Government Response Tracker, specifically the stringency index and the economic support index, which reflects the national containment policies and the national economic support. Higher values indicate more stringency and more economic support, respectively. And for the pandemic severity, we used the daily COVID-19 death rate, because we need to control for that as well. So in the analysis itself, we used the first 10 come-year survey waves. from April 2020 to November 2022. For the well-being, we use the standard life satisfaction questionnaire we, as many papers even in this conference have used on a 0-10 scale. And importantly, we divide the workforce, so the workers into three sectors, mainly three groups: healthcare workers, other essential workers, and non-essential workers. And we are able to distinguish these three groups based on one question answered in the very first wave of CAMER, which basically asked the respondents in which essential sectors they were working into. So unfortunately, this question was asked only in the first wave. So essentially what we did is to keep respondents who never lost their jobs or never changed their jobs over the time. So we're sure that whatever they answered in the first wave, they remained in the same essential sector in our analysis as well. So for us, this information is time invariant. Also, maybe importantly, or at least I get this question quite a lot, so we only observe the sector. So for instance, for the healthcare sector, we do not know the occupations. We do not know if they're nurses, doctors, or if they work in the administrative sector. We just know that they are in the healthcare sector more generally. And also, we do not know the specific location of the residents, of the respondents. We just know the broad area, so we cannot really disentangle if there are more detailed effects in a geographical level. So we just employ these simple OLS regressions, where essentially life satisfaction is our outcome. Of course, we interact the EWU, which is the employment sector, with the pandemic variables. We control for many characteristics in X, which could also affect life satisfaction. We always include country fixed effect and wave fixed effect. And also in equation 2, we further add the individual fixed effect mu(i). And of course, in this case, all the time invariant variables are subsumed, as we know. So as I mentioned, we only keep respondents who are always employed in the period analyzed of the working age with valid life satisfaction information, and who also are present at least twice in the survey because of the individual fixed effect that we include in equation 2. And as I mentioned, respondents have not lost their jobs or changed their jobs throughout the period. As in every paper with longitudinal data, we also have attrition. However, the probability of dropping out from the survey or being excluded from our sample is not different between the three groups of workers. So in theory, it should not be a concern for our analysis. And the final estimation sample is around 3,500 individuals overall. Of course, some people might argue that there is a selection into each different sectors, working sectors. So we check for this using multinomial logic, predicting the probability of being employed in each sector. And we do find, in short, that there is a selection into the healthcare sector and also into the other sectors, and this selection is not random. So in particular, healthcare workers are more likely to be women, more educated and wealthier, other essential workers, older, male, less educated and with more children, and non-essential workers, younger, more educated with fewer children. So of course, we need to try at least to address this selection issue. If not, our results would be biased. So as we know, the gold standard solution would be to exploit some form of exogenous variation in the probability of being employed in each sector. But this instrument is quite hard to find. So what we did to tackle this issue was, first of all, to include the set of control variables in all our estimations, X. And also, if we think that the determinants of sorting into each working sectors are time invariant, and as well as our EWU, our working sector, is time invariant, then when we include individual fixed effects, these fixed effects should eliminate the bias linked to selection. And so, of course, the equation with the individual fixed effect is our preferred specification. So these are the results of the first part of the paper, when we wanted to see the life satisfaction on average of healthcare workers compared to the other two groups of workers. So what we can notice, first of all, is this double humped pattern of life satisfaction, which is the case for all three working groups. And importantly, what we can notice as well is that healthcare workers, which is the little dotted line, always report a higher life satisfaction than the other two groups of workers. And this is the case for the entire period. In come here, we do not have data predating COVID. So with this figure, we only plot the life satisfaction, but we do not really know if there has been a change in life satisfaction or if happier individuals selected into the healthcare sector, which could potentially bias our results. So what we did to look into that was to take other two well-known data sets, the UKHLS and the SWAP data set, taking the data predating COVID, still dividing the respondents of these two data sets among the three groups that we have in our paper. And in this case, we still see that even before COVID, healthcare workers always report a higher life satisfaction than the rest of the workforce. So these figures here should at least make us happy in the sense that it does not seem that we see a selection of happier individuals into the healthcare workers as the pandemic unfolded. So after this, we wanted to see if this life satisfaction pattern could be somehow explained by the pandemic evolution and pandemic policies. So the unbroken black line is the point estimates without the inclusion of pandemic variables. We see that the double hump pattern still holds, and basically all the point estimates are significant. However, when we include the pandemic variables, which is the dotted line, all of them, apart from June 2021 and 2022, all the point estimates become insignificant. So indeed, it seems that the pandemic variables largely explain what we found in terms of life satisfaction trend. So these are the table of the main results. Hopefully you can see it. The top part of the table is what we have seen in the first figure, with healthcare workers always reporting a higher life satisfaction than the rest of the workforce. And even if we add throughout the columns the time invariant and time varying characteristics, we can see that how do I point this? Well, we can see in the first line that the point estimates doesn't really change that much. When we look more deeply into why is that the case that healthcare workers potentially have a higher life satisfaction, if we look at the stringency policies, when more stringent policies were in place, healthcare workers were not affected in terms of their life satisfaction, but the other two groups of workers experienced a drop. And in terms of COVID death rate, any increase of 1 standard deviation in COVID death rate corresponds to a decrease for healthcare workers of about 9% of a standard deviation, which is 3 times larger as the drop experienced by the rest of the two working groups. And also, just to give you a reference, this 9% of decline in standard deviation corresponds or equals to somebody passing from a household income of around 2,000 and 8,000 euros to an household income of below 1,000 euros. So this is quite a huge gap in household income change, and this is and they also experience a similar drop in income. So what I'm trying to say here is that healthcare workers really experienced a drop in their life satisfaction. We also tried, of course, a number of robustness checks. I'm not going to go through them in detail, but essentially they all confirm our main results, which are reported in the first column. So now we wanted to look at the mechanisms. So why is it that we found these results? So if we look at the stringency index, what we did was to try to do the same analysis, but with different outcome variables. So we first of all looked at the days spent outside in a week and also working hours. And if we, as we can see, for both healthcare workers, but also other essential workers, when more stringent policies were in place, both of them, they increased the days spent outside and also the working hours, which is what we would expect. They were not under the stay-at-home orders. However, in our main analysis, we found that only healthcare workers were not affected in terms of their well-being. So this is why we think that this result might indicate that healthcare workers derive this sort of social prestige and meaning from their profession. If we look at the COVID-19 death rate, in this case, we first looked at being worried about COVID and also tested positive in COVID. And then we saw that in this case, healthcare workers were more likely to be worried for COVID, but their likelihood to be tested positive was not different compared to the rest of the workforce. So this could mean that healthcare workers were of course, more in close contact with infected patients. So, and they might also have more knowledge about COVID itself. So that's why they could be more worried. But the precautions in place, especially in the working place, such as vaccines, they might have helped in at least not making them more likely to test positive. And finally, we also tested for mental disorders and sleep quality. And in this case, we found that when COVID-19 death rate was higher, healthcare workers were more likely to be diagnosed with a mental health disorder and also had a less sleep quality. So this might suggest that their working environment that they had to work into when COVID was at its peaks might have contributed to deteriorate not also their well-being, but also their mental health and quality of sleep. So just to conclude, in general, we found this double hump pattern for all workers, which is largely explained by the pandemic policies and progression. We saw that on average, healthcare workers were happier in terms of their life satisfaction compared to the other workforce. And why could have been the case? Well, if we look at the stringency, healthcare workers might have derived this job-specific meaning. However, when deteriorated working conditions were in place, healthcare workers suffered a lot. So just to think about what we can learn from this, maybe also taking it outside of a COVID perspective, we've seen that healthcare workers experience this large drop in well-being when deteriorated working conditions were in place. And we also know that worse subjective well-being is associated with a higher likelihood of quitting their jobs. So ideally, if we can manage to provide a good working environment for healthcare workers, this could yield the social benefits, such as reducing turnover and also improving the quality of healthcare services delivered. So that's it. Thank you a lot.
Very fast questions and even faster answers.
I will.
To channel some of the critics of lockdown policy, one might say that a lot of the fuss and policy around COVID was directed at looking after healthcare workers. Like the number one priority was to not have the hospitals too overrun. I mean, maybe that reflects social panic, preventing social panic as well, but a lot of it was framed around looking after these people from having complete madness. And so the question, I just wonder whether an extension here is to think about the trade-offs involved in if there's work done on impacts of lockdown on the rest of society. Can you say anything about trade-offs of looking because your conclusion was maybe sort of natural, right? Like if you have something unpredictable like a COVID pandemic, then healthcare workers are going to suffer. But maybe that's not enough maybe to be useful for policy. We might need to know what the costs are of alternate policies.
Yeah.
I don't know.
Yeah.
If I made any sense at all, but this is maybe a longer discussion.
If there is anyone else, if not, I can quickly. No.
I have a comment that would be really interesting work and important, I would say, but it would be really interesting to see what happened after.
Yeah.
Because maybe politics priority have changed, and the workers, maybe I would really be interested to know how much satisfied they are now.
No. So briefly. Sorry.
It's a very quick question. In your group of countries, compliance with public policy to contain the virus has been different and also changed over time. I wonder if different degrees of compliance could have helped the well-being of people in this sector.
Yeah. So quickly, okay, maybe this one. I mean, yes, it could be. I mean, we do always include the country fixed effect and wave and time fixed effect. So in theory, if every country has a different, but we control for that, I think we could over time. Yeah, but I mean, we do have those fixed effect, and so I think it could be. And for the longitudinal, yes, we were thinking about it. The problem is the attrition that we have in this data set, and so we do not have people, you know, we cannot follow the same people because, as I said, these sectors, we only have the information in wave 1. So we need to have a number of people that were present in wave 1, and we are still following them nowadays. So we tried to look into that, but the number of people that we had in our data set was really, really low. But of course, it could be super helpful to know even now how it is. And about the policies, yeah, I mean, of course, governments tried to protect, yes, as you said, protect healthcare workers because they were the one frontline trying to fight the disease. But I guess, in fact, in this case, we see that when the pandemic policies, the stringency was high, they were not really affected. It's just when the COVID itself was high, that's where they got affected the most. So in a way, government were also like protecting them. It's just when COVID was really high, then they had overcrowded hospitals, I guess. But yeah, but we can continue more later. Yeah, thank you.